Hello, now for a really important part of the programme, the Helen Lester Memorial Lecture. Many of those who you will be aware, but for those of you who are new to SAPC, Helen was Professor of Primary Care at the Universities of Manchester and Birmingham. Her main interests were in primary care mental health, and she was an advocate for underserved groups such as the homeless and people with severe mental illness. Her work influenced NICE guidance on the care of people with mental health problems, particularly with a focus on the physical health and the important role of primary care in supporting these people. Helen's James Mackenzie lecture, which you can still watch on Google, called Being Bothered About Billy, stressed that all GPs should be bothered about Billy. Helen also played a leading role in the development of the Quality and Outcomes Framework, the QOF. Since Helen's untimely death in 2013, and I have to note that she worked incredibly hard even when she was seriously ill, we have held the Helen Lester Memorial Lecture and invited speakers with an interest in areas that resonates with Helen's to present their work. This year, I'm incredibly pleased to introduce Wendy Webb, who's an advanced nurse practitioner with extensive experience in palliative care. She's passionate about improving healthcare provision for some of the most marginalised groups in our society. She was awarded a Florence Nightingale Foundation Research Scholarship for the first 2 years of her PhD research, which explored end-of-life priorities with the homeless population. Prior to commencing her PhD, Wendy also carried out research exploring perceptions of hostel staff providing palliative care for homeless people. Wendy is a Queen's nurse. She has worked with people experiencing homelessness in a variety of paid and also voluntary capacities, and is now working as a lead advanced clinical practitioner for physical health within a low-medium secure forensic mental health unit. Wendy's presentation is Life's Hard and Then You Die, End-of-Life Priorities Within the Homeless Population, and will be followed by the opportunity for questions, so please do add them to the question and answer box to the right of your screen. Now over to Wendy.
Good morning, everyone. It's such a huge privilege for me to present this 7th Helen Lester Memorial Lecture. When Professor Chew Graham contacted me about this, she explained that the lecture series was established in memory of Professor Helen Lester, an inspirational GP and academic who made a difference to the lives of so many people. Helen challenged us all to think more creatively about many things, but especially about mental health, and to think differently about the needs and care of people with complex and long-standing mental health problems. And when I listened on YouTube to Professor Lester's 2012 James Mackenzie lecture entitled Being Bothered About Billy, I experienced such an affinity with Helen's work around homelessness and mental health. Like Helen, I've also worked in Birmingham city centre, running a drop-in clinic for the city's homeless community. And now I'm working with people experiencing even greater marginalisation and health inequalities. I now work within a medium, secure, forensic mental health setting. So the men I now care for are either sectioned under the Mental Health Act or are serving prison sentences. Many of these men have also experienced addiction issues, homelessness, and adverse childhood experiences. The health inequalities they face are stark. But today, as part of this SAPC Living Well and Dying Well conference, I want to share with you the findings of my PhD research, exploring end-of-life priorities within the homeless population. I'll be sharing what matters most for the homeless people I interviewed when they considered their own end of life. And I really do hope that this short lecture today will be an appropriate lecture in memory of such a remarkable professor, Helen Lester, an outstanding academic and GP with a deep passion to address inequalities in healthcare. And I'll begin this lecture in the same way that Professor Lester began the James Mackenzie Lecture in 2012, with a poem. Crystal leaves on leafless branches that appear dead, I dragged along like the season. carrying the load of my heart, this everlasting duress. My eyes only see the smog-filled skies. Great celestial one, where is your shine? A mind dense with thoughts now abhors the delusions it cultivates. The night's cold fingers grasp the core of my soul, while thoughts drift away to a familiar place where voices with soft words soothe a crying child. But my eyes expose the curse of my surroundings, and I consoled myself with the thought of not being alone. Yet I alone share the contents of my head. I yearn to awake from his dream, my companion on this concrete bed. This poem by Earl Francis Brown is simply called Homeless. For me, it speaks of how, for people living on the streets, life's hard and then you die. So, my PhD, exploring end-of-life priorities of people experiencing homelessness here in the UK. All research begins with a question. And the central question of my research was this: what matters most to people experiencing homelessness here in the UK when they think of their own end of life? Now, this is a question which a few years ago was literally burning a hole in my soul. You see, I'm a nurse who's worked in 5 hospices. I've also worked in homeless shelters and soup kitchens and outreach teams. And I'd previously conducted a piece of research exploring end of life within the hostel setting. Now, the findings of my master's research bothered me. It really upset me that hostel staff were struggling to access support for residents with advanced ill health. Yet it also warmed my heart and humbled me to see just how hostel staff would really go the extra mile for their residents in an effort to compensate and to provide some dignity and compassion at end of life. And it bothered me that people experiencing homelessness were and still are dying young, often from preventable diseases and often without adequate support. Now, as I started out on my PhD journey in 2016, the Care Quality Commission here in the UK published several important reports which highlighted the inequalities for people experiencing homelessness at end of life. And these reports called for change to address these inequalities. Now, at the time of their publication, I was working in the hospice sector, and I witnessed hospices up and down the country scrambling to make their inpatient beds more accessible to the homeless community, but no one had actually stopped to find out whether admission to a hospice is what people experiencing homelessness here in the UK would actually want at end of life. You see, no one really knew what our homeless community here in the UK prioritised at end of life. This research question had been asked in Canada and in the States, but it hadn't yet been asked here in the UK. This question remained unanswered, and so my journey began. So 21 participants, that's people currently experiencing homelessness, they were interviewed face-to-face across 5 research sites, and transcripts of those interviews were analysed using thematic analysis, and then the findings were viewed through the lens of Maurice Merleau-Ponty's philosophy. Now, I don't have time today to delve into the methodology, but let's say that during the interview I asked lots of open questions. Questions about life in general, about sudden illness, end of life, and care after death. And these questions gave participants the opportunity to talk about their own concerns, fears, preferences, and priorities in each of these areas. And I was surprised by the amount of unsolicited disclosure Participants needed to tell me about the trauma they'd endured in life, the losses they'd suffered, the drugs they'd taken, the sentences they'd served. They really held nothing back. In fact, in some interviews, my own research questions didn't even surface until the participant had talked for half hour or so about what was on their own heart. It was as if they saw this as their chance to be heard. This for me was very poignant, and some interviews were extremely hard to transcribe. But this extra information, this unsolicited disclosure, this outpouring, this soul-bearing was really significant. Now, according to Merleau-Ponty's philosophy, context is everything, because life is always experienced in the context of time and space. So a view is always a view from somewhere, from a specific perspective. And so in my thesis and in this presentation and in the paper I've already published, I considered it important to report some contextual themes from the data, so that people can understand where the participants are coming from. So I've reported 4 contextual data themes around the issues of surviving and coping. And these data themes, they don't really represent actual findings of the research because they don't answer the research question. However, they do help us to understand the context of the findings. So looking at these contextual themes, they tell us that participants tend to live in survival mode, looking after number 1 and living one day at a time. They've also learnt to cope and to be resilient. And as far as coping goes, yes, some participants had turned to drugs and some had even attempted suicide. But others had turned to God for strength and support, and most had learnt to laugh in the face of adversity. And so on to the actual findings. What was the answer to my research question? What did the people I interviewed prioritise when they considered their own end of life? What really mattered most to them? Well, I reported 8 themes which came up repeatedly. Themes which speak of common concerns, fears, preferences and priorities. Let me list them first. So there were spiritual concerns and practical concerns. There was a fear of needing care and a fear of being forgotten after death. There was the preference for dying suddenly and unexpectedly, and the preference for being somewhere they are known and understood. Then there was the prioritising of autonomy, this desire to stay in control of decisions, and a prioritising of authenticity. That's about being real and authentic with others. So let's take a closer look at some of these themes and pick out what's particularly interesting to note. So, participants generally did not fear death. In fact, they were almost immune to it. But they did fear needing care. When asked about preferred place of care at end of life, Ray said, "Oh, give me a needle. Why make me suffer?" George said, "Ending up in social care. That's my idea of hell." And Owen simply said, "Throw a toaster in the bath with me." What else is interesting, though? They feared being forgotten after death. They seemed to be saying repeatedly that they wanted and needed their lives to be counted as significant by someone. Jack said, "When you're on the street, it's like you've got no identity." And Derek told me he'd written his biography and got 2 copies. But what else is important? Well, there was a general preference for dying suddenly and unexpectedly. Jason put it plainly enough when he said, "I'd rather drop dead." And George explained how sometimes for people who are homeless, it's better not to know a diagnosis. And what else is important to highlight? Well, participants prioritised authenticity. The interviews were candid and gritty, and sometimes even harrowing. They really held nothing back as they recounted life stories to me. They repeatedly expressed the sentiment that they wanted to be able to be themselves, and that what you see is what you get. One message that came through loud and clear is that they can't bear hypocrisy and people who hide behind masks, and I don't mean PPE masks. Now, I'm aware that I am really skating over the surface of these findings in order to point out some of the more important or unusual findings. So if any of you would like me to send you my published paper, please do email me and I'll happily share it with you. But is all this really new knowledge? There had been similar studies in Canada and the States, certainly. But this study reveals the previously unreported UK perspective. This study reports the end-of-life concerns, fears, preferences and priorities of the homeless community within the UK, which couldn't just automatically be assumed to mirror those concerns of people experiencing homelessness elsewhere or of the housed community. Now, within this research study, I've compared the individual perspectives of the 21 participants, and I've searched for similarities and differences, for commonality and uniqueness. And in the discussion chapter of my thesis, I also compared the findings of my own UK research with the findings of similar studies abroad, again searching for commonality and uniqueness. And here's what I found. 5 of the 8 themes I've reported correlate with the findings of similar studies abroad. So in the UK, as in other countries, homeless people expressed concerns of a spiritual nature and wanted to talk about existential issues such as suffering, unanswered questions, regrets, forgiveness, reconciliation, hope, fears. In the UK, just as in other countries, people experiencing homelessness fear becoming physically dependent on others for care, and they fear being forgotten after death. And in the UK, as abroad, participants would prefer to be in a familiar environment and they want to remain in control and make their own decisions. Now, these common themes aren't really surprising because many of the risk factors and indeed the challenges and consequences of homelessness will be pretty similar across different cultures and countries. But, and this is what's interesting, people experiencing homelessness in the UK also have some very unique concerns which are previously unreported in similar studies conducted elsewhere. So what findings were unique to this UK study? There are 3. Firstly, in the UK, the pauper's funeral was mentioned repeatedly. Many spoke about the cost of funerals and how they expect to have a pauper's funeral. And here in the UK, the pauper's funeral is still a potent symbol of 20th century poverty, and it's often associated with the workhouse, where people who couldn't afford healthcare years ago were sent to die. The pauper's funeral and the workhouse still symbolise loss of dignity in death here in the UK. And secondly, the participants that I interviewed expressed a preference for dying suddenly and unexpectedly. And while we know that this is in fact how many homeless people die, it's not previously been reported that this is how they wish to die until now. This has not been reported in the literature as a preference. And then thirdly, in the UK, the preference for being real and authentic was also communicated very clearly, and this is also unique to this UK study. No other studies report the importance of being around others at end of life who are equally real, authentic and transparent as they consider themselves to be. But what does all this mean? What's the significance of these findings? In summary, we now have evidence that people experiencing homelessness here in the UK live one day at a time in survival mode. They're not afraid of death, but they don't want to plan for end of life. They'd prefer to drop dead suddenly one day than receive a palliative diagnosis and need care. They have little interest in traditional palliative care services. They worry about paupers' funerals and being forgotten after death. They want to remain around people who know and understand them and who are as real, candid and authentic as they consider themselves to be. For this population of society, life's hard and then they die. Hopefully, suddenly and unexpectedly. But now what? What do we actually do with this new knowledge? Well, viewing the findings through the lens of Merleau-Ponty's philosophy enabled me to visualise a new approach to providing care and support for homeless people with advanced ill health. Homeless people who may be approaching end of life. An approach which sits comfortably within the current public health agenda of involving communities in the provision of palliative and end-of-life care. I'm talking about a collaborative, alternative approach to traditional hospice and community palliative care services. A strengths-based, compassionate community approach to care, with hostels as the hub of the compassionate community. So let's spend the last few minutes thinking about this, because homelessness is such a massive problem that it's easy to feel totally overwhelmed when thinking about how best to support people experiencing homelessness at end of life. So the first thing to remember is that no one organisation or service can do it all. We all need to work together as a community, and we need to involve and train up peer support volunteers. That's people with lived experience of homelessness. Peer support volunteers are an essential cog in the wheel of palliative and end-of-life care support for the homeless community, as are the mental health support teams and substance misuse teams. Now, when we think of community-based palliative or end-of-life care, we think of GPs, district nurses, hospice teams and care agencies all working together. But we need to remember that hostel staff have some very unique strengths for us to draw upon when caring for people who are homeless at end of life. Hostel staff are resilient and compassionate. They provide creative support amidst chaos, and they are very much aware of the need for a trauma-informed approach. They have a good understanding of addiction and harm reduction issues, and they already work closely with mental health and substance misuse teams. They're used to managing complexity, and most importantly, they already have established relationships of trust with the people who are experiencing homelessness. But people with lived experience of homelessness have their own unique qualities that are often untapped, which is why peer support workers are so valuable. They have countless strengths, such as resilience and inner strength, a sense of humour. They're authentic, candid communicators. They have an innate ability to improvise, and they appreciate and recognise genuine kindness and compassion. They also obviously have that shared lived experience of homelessness, which will enable them to offer peer support. So it's about looking at how we can work together to make a difference. GPs and district nurses can't do this on their own, and hospices can't do this on their own. More than ever, with the homeless population, we need to work together. We need to be creative. We need a can-do, compassionate community approach. We need people across the different services, each with creative vision, people who see the possibilities and people who aren't afraid to bend some rules. So let's work together with passion, with commitment. with creativity and with a healthy dose of rule bending. To make sure that people experiencing homelessness receive timely, high-quality personalised care and support when they have advanced ill health and may be approaching end of life, let's make sure that these people who live one day at a time in survival mode, who are not afraid of death but don't want to plan for end of life, who'd prefer to drop dead suddenly one day than receive a diagnosis and need care, these people who have little interest in traditional palliative care services, these people who worry about paupers' funerals and being forgotten after death, these people who want to remain around others who know and understand them, and who are as real, candid and authentic as themselves. Let's work together to make sure that these people receive the same high-quality care at end of life that we would want for ourselves or for our own families. Thank you for listening. Please do email me or contact me on Twitter if you'd like to receive a copy of my research paper.
Okay. Thank you, Wendy, for a really interesting talk. I'm Sue Richards, and I'd like to welcome Dr. Wendy Webb to answer a question which has arisen through the chat. We have 5 minutes, so if your question isn't addressed fully, please do contact Wendy after this talk on the message page. Wendy, the question was from Merlin Wilcox. I'm praying now. Can you tell us a little bit more about your sample of interviewees, and were they at end of life themselves? Could you answer that one a little bit more about your sample, please?
Yes. So in the inclusion criteria, they did not actually have to be. They did not have to have a palliative diagnosis, but I did actually only interview people in the older age range. So for the homeless community with having a life expectancy often in the 40s, it was females over 37 and males over 40, if I'm remembering correctly. So that was considered to be older adults rather than young people and teenagers, and it wasn't a requirement that they had advanced ill health, although many of them did and were very willing to share their diagnoses with me. So there were people who had alcoholic related seizures, and they talked about those. There were people with COPD, so a variety of long-term conditions and poor physical health, but not actually a palliative diagnosis, not actually having been told that they are facing end of life.
And just very quickly, we've got a couple of minutes left. When the sorts of issues for end-of-life care might include things which are related to perhaps lifestyle, such as ongoing alcoholism, did people talk a little bit about the different sorts of issues that they were worried about towards the end of life?
I wouldn't say specifically, but one of the themes was about retaining control and autonomy, and that means actually making their own decisions right to the end of life, and for some that most definitely would have included drinking right up to the end of life, and also substance misuse. And this is what makes it so difficult to care for this population within the usual environments. I think even hospices struggle with the substance misuse component that is often a feature of participants' lifestyles.
Okay. We're almost out of time now, Wendy. I'd like to thank you very much for giving this really important lecture within the SAPC annual calendar. We're now heading towards a short break before we join the next keynote sessions, which are all to the theme of living well, which is Port Aviard and Tom Williams. So see you back in 10 minutes on the platform. Time to go and find your kettle, and thank you for joining us.